Hello guys, this is Dr. T and welcome to my channel, Clinical Medicine with Dr. T. So guys, yesterday, I'm gonna try to be very quick guys. I think it's about 6:30 in the morning and I need to get ready to go to work, so I'm gonna be very quick on this one. So yesterday we started this series on PMTCT, prevention of mother to child transmission of HIV. So just to recap a bit, so we said that trying to prevent the transmission from the mother to the baby doesn't start when the mother is pregnant. It doesn't start when the mother has delivered. It starts before she conceives. That's called preconceptual. And we did discuss. I'm not gonna get into details, guys. Please go back to part 2 of this series where I explained that in detail. So we did explain that we would want someone who is HIV positive to actually engage with their healthcare provider to say, I'm HIV positive and I want to have a kid, I want to have a baby, and then based on how suppressed her virus is, then that's when the doctor or the nurse can say, oh, okay, the right time to actually, and we did speak about this thing of safe conception. So that's what it's about here. It's about safe conception. When is the right time for a person, for a woman who's HIV positive to actually fall pregnant? The right time is when she's virally suppressed. So we want that viral load to be undetected. If not, at least less than 400. And we want her not to be a stage 3 at least, or a stage 4 in terms of the World Health Organization, right? So that's that. So if this lady wants to get pregnant but we don't know about whether she's suppressed or not, she needs to be on a contraception until she is suppressed. She needs to be on a contraception until she is suppressed. So that's what a preconceptual, those are the things that we want to do. So, and then we did speak about antenatal. Now, unfortunately, like I said yesterday, most of our women, we get them here. When they come, they say, I think I'm pregnant, and then when you do a scan, they're already like 3 months, they're already 4 months, some even 5. I'm not kidding you guys. There are instances where the mother would come in at 9 months. They come in just to deliver. They have never been to a clinic to do any kind of workup, so it becomes difficult. So with the antenatal, the first visit, this is in summary, the first visit of a testing, if it's negative, she needs to test every time she comes for her basic antenatal care, every time she comes until she goes to deliver, if she's negative. If she's positive, ART initiation, bloods, counseling, support, that kind of a thing. What I want us to talk about now is intrapattern. What happens when the lady now comes in and she's for delivery? That's called intrapattern. I'm not kidding you guys. There are people that come when they, like I just explained, they just come during that time when they are to be delivered. So Intrapattern, again, offer testing. So there are two things here. There are those who are positive already. There are those who are negative. Those who are positive, it could be that they were picked up during the antenatal period, or they were already known. Their HIV cells were already known, and they were already on treatment, right? And if the antenatal was done well, by this time they should have a VL that is less than 3 months old, a VL that has been done within 3 months or within 12 weeks. So that's a good thing. As much as we are still gonna do a VL at the time of delivery, I will tell you why this is important. Maybe you might want to say, okay, if the VL was done a week ago, 2 weeks ago, or within a month, maybe you might say, oh, okay, let's not do the delivery. But it is recommended that we do a viral load at the time of delivery, right? So I'm saying, this is Intrapattern. The lady now is here to deliver. What do you do with her? You check the, you want to know, are they known with HIV or are they not known? If they are known, you want to know, when were they diagnosed? Was it during the antenatal, or was it they were diagnosed before pregnancy, or they've been on treatment even before pregnancy? Those are the things that you want to know. And also you want to know if they've not defaulted, because that's another thing. Because you can have someone who's known but they've not been on treatment. Because there's always a story of I started a new job, so I couldn't take treatment, I moved, I changed provinces, I changed location. So there are those things as well. So the fact that she's known does not mean she's on treatment. She might be known but not on treatment. She might be known with the HIV but is not on treatment. So those are the things that you must establish. So pay attention to someone who has defaulted. Doesn't matter the reason why they defaulted, doesn't matter. So take care of that. So now, what happens to someone who says, I have been negative throughout, I was negative preconceiving, and I've been negative throughout my antenatal? Are you gonna say, no, there's no need to test? Actually, there is a need to test. According to this guideline, they need to be tested again when they come for their delivery. Because when they come for their delivery, they might come in. So their test during delivery can come in. So I'm talking about these ones now who are negative. They come in from home to deliver. They know themselves to be negative. I mean, it doesn't make sense that you're gonna test someone who knows that they are positive or who are already on treatment. Doesn't make sense. So this is someone who says, I have been negative, I've been testing negative. So because they come to deliver, you will test them again. And that test can take 2 parts. It can now become positive or it can remain negative. If that test becomes positive now, what do we do? What we do is you give the state dose. So you're gonna obviously have to cancel the mother and tell them that, okay, this is what the test looks like, and this is what we need to do, and these are the drugs that we need to give you, these are the side effects of the drugs, and all that. So obviously you're gonna do that counseling test, and then also post counseling, that type of a thing. So but I want to focus on the drugs. So here the drugs that are given now is the TLD. So they need to get TLD, the state dose, and NVP, state dose. TLD, this is tenofovir, this is lamivudine or 3TC, and this is dolutegravir. So it's 3 in 1, as we know, in one. And then that nevirapine. So that's the state dose that they will receive when they are found to be positive at the time of testing intrapattern or during delivery. What happens after? What needs to happen after they've had the state dose? On the following day, they need to be started on the lifelong ART. This is like the emergency kind of a situation. So the person who's going to receive this is the person who has been negative throughout, but during delivery, now they are found to be positive. That's what they're going to get, right? And also, someone who has been known with HIV, they were diagnosed, but they defaulted, they're also going to get the TLD as well. Because we don't know how virally suppressed are they, and if they need to deliver, if they're going to deliver within 12 hours or within 24 hours, we're not going to wait for the VL and decide what we're going to do. So we need to be safe. So, but if a patient has been on ART, they didn't default, probably they were started their ART even before they got pregnant, or they were started during the antenatal period, they don't need to be given the emergency state doses, right? They just continue with their ART as usual. Okay, now that's fine, that's good, that's lovely. Yes, obviously screening them for TB and checking if they've got other co-infections, yes, will be part of their management. Now, what is, in terms of the delivery, how should they be delivered? Previously, when you were positive, when you were HIV positive, it was equals to a Caesar. There was just no discussions, there was no two ways about it. Once you are found positive, it was a Caesar straight. Because it was believed that NVD carries a lot of risk. That's actually a time when the chance of transmission were very high. So it was, and at that time there were so many C-sections that were done, and because there were so many C-sections that were done, you would have someone who's had 2 Caesars at 25 years already, or even sometimes at even 20 years, and mothers were dying because, I mean, Caesars have got their own complications, right? People died in theater, people died because of infections, all that, and all of that. Yeah, well, and so, but now it's no longer the case. Someone who's positive, they can go for a C-section if there is an indication. And the indication to do a Caesar is the same indication for like in everyone else. Like, not because now they are positive, now they're going to have a Caesar. If they don't have an indication for a Caesar, then they won't have a Caesar. But if it happens that they go for a Caesar, they should be on antibiotics, prophylactic antibiotics. Remember, and this is, it depends where you're working, but the guidelines, that's what they say, that when you are positive, you should be, I mean, it makes sense that you get antibiotics if you are positive. But then there are centers where people get antibiotics whether they're positive or not, as long as they were done the C-section. But what matters now for this discussion is that never forget the antibiotics after Caesar. Now, what are the things that should not be done? That's the mode of delivery, right? Ne? That's the mode of delivery. So what are the things that should be avoided? I mean, women who are positive, they do NVD now. There's no problem. They do NVD as long as they can actually deliver their own babies, and there is no contraindication to the NVD. So, what are the things that should not be done? The things that should be avoided on someone who's HIV positive is rupturing of membranes. You know, when we want to stimulate labor, someone has got prolonged labor, and we think that if we can rupture their membranes, they will actually progress fast. If you find that, if you are thinking about that, but when you flip back on their card, you find that they're HIV positive, you are gonna not rupture those membranes. But we have ruptured membranes for a lot of patients, especially when I was in the district, of those who were HIV negative and their labor went well. But rupturing, this is artificial rupture, right? Artificial rupture of membranes is contraindicated in HIV positive women. Another thing that should be avoided is episiotomy. I mean, most of us know what an episiotomy is, but it's actually when you are doing an NVD and the head is almost out, and the midwife thinks that if they can just extend the passage, you would actually deliver so they make a cut that is about maybe a centimeter or 2 or 3 depending, and then the baby comes out, and then they stitch that afterwards. So it should be avoided when you are HIV positive. Another thing that should be avoided is excessive suctioning of the baby. Excessive suctioning of the baby should be avoided. So these 3 things are very important. They should be avoided because it has been found that the work that we have been doing trying to prevent transmission, these are the big culprits in terms of transmitting, right? Now we are done. Our mother is now delivered. What happens now when our mother has delivered? Contraception becomes very important. Contraception is not yes, it's important. It's important even if you are not HIV positive, because it allows you to take care of the baby that you have. It allows you to actually space your babies according to the way you want, according to yes, so that you don't want to be neglecting the one that you have. So it's spacing. So it's just that's why it's called family planning. You are planning how you're gonna have your family. So that's why it's called. So all women should be on contraception after delivering. Yeah, and it becomes very important, especially if you were found to be positive during delivery, because you don't want to have a second kid very soon and you are still not virally suppressed, or there are just problems with your suppressing your virus, or the virus in your body. Let me put it that way. So that's that. So you should be on a good on a reliable contraception. And then now, what happens to the baby? Let's talk about the baby. Our lovely baby. Say now we have done all of these things. Now our mother has delivered, and now we have a baby. That little bouncing champ. Or let me just say newborn. Or infant. So now what happens? What's gonna happen is we want to classify this infant as a low risk or a high risk. high risk to get the infection or low risk to get the infection. So a baby that is a high risk is a baby whose mother has got a VL of more than 1,000 copies. More than 1,000 copies, and that's a VL that has been done within 12 weeks prior to delivery. Or they are unknown, or the VL is unknown. The VL is unknown. This would be someone who is known with HIV, but they were not following up, so they were not doing those bloods. Or someone who was just found to be positive at the time of delivery. That someone was unknown. So that's a high risk infant. And because of that, they need to be on dual therapy. And dual therapy, come on guys, is it early in the morning? Dual therapy. And dual therapy is made up of NVP and AZT. A low risk infant is just the opposite of that. Someone who's virally suppressed, VL is less than 1,000, virally suppressed, and this person has been on ART, has been compliant, maybe they were diagnosed, now they've been compliant. And the drugs that they receive is just monotherapy, which is just the NVP, right? So this is why we need to know the viral load. We need to know that viral load, because the viral load, as you can see, it determines, so we use it to classify the infant, whether high risk or low risk. It's not based on the mother's CD4. It's not based on the mother's CD4, but it's based on the mother's viral load. If, as we say, that the unknown ones would be someone maybe has not been on treatment, is known to be HIV positive, but they've not been on treatment. Maybe they've defaulted, so whatever the reasons, but they've not been on treatment. Or someone who was just found to be positive when they came to deliver. That's unknown. We put them on the high risk. The VL that is done during delivery, when they come in like 3 or 6 days, the results might be out, and then now we can reclassify. Let's say now this one is unknown, you put them on 2 drugs, but when they come in later on, 3 to 6 days, the VL is actually less than 1,000. You reclassify the infant as a low risk, and you can now readjust your treatment, put them on NVP alone, right? Okay, so so very, very, very important, very, very important, very, very, very important. So if the mom was negative, mom is negative before she conceived, mom is negative during the antenatal period, mom is negative during delivery, then we can say mom is negative. So that kid does not need to be on any treatment, right? So now part of so we cannot finish this topic if we're not going to talk about the feeding methods. Maybe you ask yourself, how long should the baby take these prophylactic drugs? The answer is, it depends on first the method of feeding. You know, a baby can either be when it comes to feeding infants that are born to HIV positive mothers, we need to decide how we're going to feed them. The mother needs to be educated about that, to be counseled about it, because they shouldn't do mixed feeding. The options that are there generally is what is called mixed feeding, which is not recommended when you are positive. Mixed feeding or exclusive. Exclusive feeding can either be exclusive breast, or exclusive formula. Another thing, like I said, that there's a lot of research that has been put together. I mean, if there's one aspect where we can actually appreciate from our department, is National Department of Health, is this protocol. Guys, this protocol, there's a lot of work that has been put here. I mean, that's why I say this, that it just makes my heart, like, I become so happy when I go through this protocol. So, if you remember, around, like I said, before 2011, 2027, 28, around there was this thing that all infants that are born to a HIV positive mother should be on formula. They should not be breastfed. And those kids died from opportunistic infections. Because remember, those antibodies, your IgA, that are from the breast, that come through the breast from the mother, are very, very important. And they are still important even if the mother is HIV positive. So they died, they were malnourished, they had diarrhea, they had pneumonia, they had all sorts of infections. And the under 5 mortality rate was very high back then. But now, no, it's not. Because a lot of work has been put, and it was later found out through research that actually, as long as they are not mixed feeding, they should be fine. So you can either exclusively formula feed or exclusively breastfeed, but not this guy. We don't want this one, right? So now, when you are breastfeeding, okay guys, I have got to, we are 28 minutes into this already. Let me do that thing on part 3. Yeah, thank you.